Very warm welcome to the 74th session of Pediatric Orthopedic Advanced Learning Session. Just a brief word about the POALS. Through this initiative, we try to connect the pediatric orthopedic trainees across India with eminent personalities. It provides them the platform for direct first-hand interaction with the expert in this field. Over time, this sessions has attracted colleagues at all level of practice, not only the trainees. Now, the consultant and even the professors, they also attend these sessions. And this is really encouragement for all of us. Now, a brief introduction about today's speaker, Dr. Sujata Sawhney. She is a pediatric rheumatologist. She is trained in UK and Australia. She practiced in Sir Gangaram Hospital for last over 5 years, and she runs a specialty training program for over 15 years. She has a special interest in ultrasound in pediatric rheumatology, childhood lupus, Kawasaki disease, and uveitis in children. I must thank at the outset OrthoTV for giving us this opportunity to live stream this program so that not like this program is attended by 15-20 people, but in 1 week time, 300 people across globe will watch this session. And also I should like to thank my colleague, Dr. Devang Pandya, who is a pediatric rheumatologist in Ahmedabad, and he's a student of Dr. Sawhney. So he helped us to connect to the speaker. So with that short introduction about the pediatric orthopedic active learning session and about the speaker, I hand over to Madam. Over to you, Madam. Thank you.
Thank you so much, Dr. Dhiren. It's such a pleasure to be here with all of you. And what I'm going to do is to talk to you about how to approach a child who presents to you with arthritis. So, in the field of pediatric rheumatology, if you want to take a shortcut, you often land into very big trouble. So, every child that presents to our clinic requires the time and the energy and a very systematic approach so that we can come to a clear understanding from the history what is the reason for the joint pain, the articular complaint of this particular patient, keeping in mind that pediatric rheumatology is actually the last bastion for the clinician. So, for our patients, 85% of the diagnosis comes from a detailed history. 10% comes from carefully examining that patient, and you have only a 5% add on by getting some fancy laboratory test done. So remember that you have to spend time with the child and family to understand what the problem is. When a child presents with joint pains, we want to look at the systematic list in front of you, and we want to be very, very simple. So let's start the first question here. The first thing you observe about the patient is the age and sex of this child. And it's important to note that when you have a child who presents to you with joint pain, look at a simple thing. What is the age and sex of the child? So, in infants under 1 year of age, inflammatory arthritis is rare. What you have to be careful about is a primary immunodeficiency or an underlying infection. The condition of Kawasaki disease and Still's disease or systemic arthritis can, of course, occur under 1 year of age, but not very common. In the older child between 1 and 5 years of age, you will see more of Kawasaki disease, systemic arthritis, and you also have in young children the presentation of conditions that have an abnormality of the innate immune system, and those diseases are called auto-inflammatory condition. As the child becomes older, you begin to see more arthritis and the classic autoimmune disease such as connective tissue disease, etc. So let's look at the first question when a child presents to you, and that question is, what is the nature of this child's complaint? Is it inflammatory? Is it non-inflammatory or in fact sinister? So from the history, you want to try to understand, does my patient have early morning stiffness? Does inactivity worsen the condition? What happens when the child goes to sleep and wakes up in the morning? Is there any associated joint swelling? Is my child able to attend to all the daily activities? And then you want to try to understand what are the blood reports of this patient showing. So, early morning stiffness, the phenomena of gelling, worsening with inactivity, getting bent better with gentle mobility. These are all features of articular inflammation. The prototype here is juvenile arthritis. The next group is the converse of this, that is a child who presents to you with non-inflammatory pains. So what's the prototypic clinical condition here? Benign joint hypermobility. How do these children present? They present more with aching limbs towards the evening hours. They have no early morning stiffness. Their condition is not associated with limping and the joint is not swollen. And your labs here are entirely normal. And then you can occasionally come across a child who has sinister joint pains. These children may or may not have joint swelling, they may have periarticular pain, they may have bony pain, but they will be having constitutional features. Their gestalt will be one of not being very well. They may have night awakening, fever, and type B symptoms in the form of excessive sweating. They are not able to carry out activities of daily living. And then when they walk into your clinic, you can see that this is an unwell child. And the prototype of a sinister joint pain is a patient who presents with acute leukemia. So, as individuals and physicians who look after children with limb and joint pains, we should know that one of the common manifestations of acute leukemia is acute monoarthritis, which can be of a migratory nature. So there are many conditions that can present to orthopedicians and rheumatologists with limb and joint pains. The second question you want to understand is it acute or chronic? And then how many joints are involved? So let's think of a young child who presents to us with acute monoarthritis but clinically looks very well. You're going to suspect that this patient may, for example, have had an acute injury. That patient may have a hemarthrosis. That patient may have a traumatic injury. Or that patient may have developed something like a slipped capital femoral epiphysis. And this is the kind of patients that we would want to jointly manage with orthopedic surgeons. On the other hand, if the acute monoarthritis presents to you in the context of a sick child, you have several differential diagnoses. Amongst them, the most dreaded is septic arthritis, but what we see most commonly in practice actually is reactive arthritis. And then you can have a host of conditions that can present to you acutely. If you have a child with a chronic monoarticular disease, a single joint that is swollen for more than 6 weeks and the child is well, then you think of several conditions that come under the category of juvenile arthritis. However, if the child is not well, if the child looks sick, then you want to consider, is the child having a partially treated septic joint? Does the child have tuberculosis? Is it a malignancy? And several other conditions as well. So even in a single joint, you have to understand, is it acute or chronic, and is the patient well or unwell? A child who can then have acute polyarthritis, that is to say more than one joint is involved, you want to try and understand that in a fairly well child, it could be a reactive or a post-viral arthritis. You can have children with Henoch, Schonlein, purpura who can have a joint involvement and a very subtle rash that you may not have picked up. For example, the rash could be present only on the buttocks and you may not have stripped the child down. So it's very important to have a full detailed examination. And acute polyarthritis, when the child is not very well, the differential diagnoses are many, and this requires a detailed history looking into fever, constitutional features, multi-system involvement, the growth parameters of the patient, a detailed systemic review, and then joint examination as well. When a child has chronic polyarthritis, again, there are several conditions that can occur. And here you have to then see, is it only joints or something more than the joint as well? So, you have now answered 3 questions. Does the patient have an inflammatory, non-inflammatory or sinister disease? Then you want to find out, is it one joint or many? And in each category, is it acute or chronic? And is the child sick or well? So those divisions help you to organize your thought process about a patient who has only joint involvement. But you want to see in the history, is it only joint or something more? And then the pattern of that particular disease, whatever it may be, whether it is childhood lupus or juvenile dermatomyositis or Henoch-Schönlein purpura, or a patient who has, for example, a primary immunodeficiency, a child who's got inflammatory bowel disease and arthritis, a child who has celiac disease and arthritis, or a child who has got a metabolic bone disease such as a vitamin D deficiency or scurvy. All of these come with just recognizing the pattern of the patient. And when it's only joints, then you want to see all the detail about the joint. So what do you want to find out? You want to find out large joint, small joint, symmetric or asymmetric, upper limb or lower limb, axial involvement or not. And you take into consideration, like we discussed from the very beginning, the age and sex of the child. When you want to look at complex diseases, you need to know all the extra articular features, and then you want to know the detail of the family history. For example, an 8-year-old boy who presents to you with a swollen ankle joint and a swollen knee joint for about 7 weeks' time with a history of an acute red eye. If this child comes in to your clinic and the father has ankylosing spondylitis, the diagnosis is very clear to you. This is a juvenile spondylitis in the child. So it's very, very important to take a detailed family history as well. And once you've taken all the other systemic reporting, you'll be able to understand, is it only juvenile arthritis, or in fact, is it an underlying connective tissue disease? Is there an underlying vasculitis? And if the patient has got a vasculitis, is it a primary or a secondary kind of a vasculitis? So let's recap and make it really very simple for all of us. We want to find out, does the child have arthritis? Yes or no? If yes, is it a single joint or more than one? And in each category, acute or chronic, standalone or multi-system. And if in case the child has got polyarthritis, in the same way, acute or chronic, standalone or multi-system. And if we find that it is not an inflammatory rheumatic disease, it is something different, then we have to consider the mimics, which can be infections, metabolic, malignancies, skeletal dysplasias, and maybe occasionally some genetic disorder as well. So, rheumatology then boils down to recognizing the pattern of the disease. So, today we are going to restrict ourselves to inflammatory joint disease, and let's look at some of the important categories of juvenile arthritis that can come to you in the clinic. So, when we say that the child has got juvenile idiopathic arthritis, we are implying that the age of onset is under 16 years, that a joint involvement has been present for at least 6 weeks, and that we have excluded other causes which are age and sex appropriate, and also depending upon the geographic area that the child stays in. So, for example, if in case we have a child who comes from the rural belt, for example, in Middle East, and that patient is having raw goat milk and presents to us with arthritis, we want to exclude brucellosis. In India, if we have a single swollen joint which is of the lower limb with some significant muscle wasting and failure to thrive, what is endemic in our country? We want to exclude tuberculosis. If you are living in that area of the Silk Route, for example, this is a Turkish patient who's presented to you with a chronic monoarthritis and occasional abdominal pain, you want to exclude familial Mediterranean fever. If this child is from the United States and has been camping in the area of Connecticut, you want to exclude Lyme disease. So, juvenile arthritis remains a diagnosis of exclusion, and what you exclude depends upon many things, like I tried to tell you, upon the age, the sex, the family history, the growth pattern, the geographic area where the child is staying. So you can't run away from looking at a very, very detailed history for every patient. So amongst the juvenile arthritis patients, one of the commonest seen, at least in the West, not that much in India, is a subtype called oligo. Oligo is a word that means few. So few joint involvement, that is four, equal to four or less than four joints. And these patients, what is the prototype? Young preschool female under 5 with ANA positive who then has a propensity for eye involvement, asymmetric involvement of the lower limbs, total number of joints less than 5. So here's a patient with a swollen knee. Here's another one with a Baker's cyst. And when you are examining the ankle joint, it's very important to look at the child from the back. And here you can see that the left ankle joint is swollen as compared to the right. And a careful evaluation may show that not only is it the joint, it could also be the enthesial side. You could also have the tenosynovitis medially in this patient. So the clinical examination of the ankle joint is fraught with difficulties, and the maximum clinical errors are made when you're evaluating the ankle joint. These patients don't have significant amount of pain, and the acute phase response is only moderately elevated. What we don't want from our orthopedic colleagues is incisions on these little knees. It's very important that if we do want to get the tissue, we should try and get it arthroscopically. And even in India, if we have a single swollen joint, there are many children who are given blind ATT, which is something we should really not be doing in the year 2026. We want to make sure that the child does not have a single swollen joint in the context of oligo-JRA. Of course, the fluid examination is also very important, and you all know the differences between inflammatory, non-inflammatory, and septic joints. So if you have a single swollen a joint, and even though it's the knee, it's not always TB. Must think juvenile arthritis and get the eyes examined, because this is the category where you can have silent chronic uveitis. What does that mean? That means it's an inflammation of the uveal tract. It is silent because the child has no pain, no redness, and no watering. It's only through a protocolized, careful slit lamp exam that the diagnosis can be picked up early on. If you pick up this diagnosis late, the eye can have multiple complications, and unfortunately, children can lose vision. So, this is not when you want to pick up the eye with uveitis, when the pupil is already irregular and you have damage within the eye. You want to pick it up early with screening. Let's move to the second subtype, which is polyarthritis. Here, these children have symmetric upper and lower limb involvement. This can either be early onset under 5 years, or it can be in the adolescent age group. Majority of these patients are negative for rheumatoid factor and for anti-CCP antibody. In fact, these antibodies are present only in 5% of childhood arthritis. 95% of children with juvenile arthritis are seronegative. So we are not looking at the rheumatoid factor for diagnosis, only for prognostication. All right. So here's an older child with symmetric polyarthritis, and here's a young infant with seronegative polyarthritis. The next subcategory is the category what is called juvenile spondylitis, or also called enthesitis related arthritis. In this condition, you can have an oligo involvement of the lower limb. More than one third of children have the midfoot involved, and this is the category where the enthesial sites can be involved, and also the category where these children get sacroiliac inflammation. Now, the sacroiliac inflammation or sacroiliitis is not common in the younger children. It is more common in the late teens and in the early 20s. The classic prototype here is a male patient who's over 6 years of age. These children can get many extra-articular manifestation, which includes the gut and the skin. Importantly, it also includes the eye, and these children get acute red eye. This is in contrast to the first category of oligo-GI, where the ANA is positive, and those children get silent eye inflammation. These children are symptomatic with painful red eyes. All right. And here's a classic presentation of this subcategory where they present with a lot of neutrophils in the anterior chamber. And this is called hypopion uveitis, where you can actually see the cells within of the anterior chamber with the naked eye. And remember that when children have an arthritis, sometimes it may be difficult to understand which joint is involved, but look at the adjacent muscle group and the significant muscle wasting there. When you look at the x-rays of children with sacroiliitis, you'll often find them normal because articular changes on plain x-ray can take up to 7 years from disease onset to present. In fact, what is much, much more sensitive is stirred images T2 of the MRI that shows you the bone marrow edema in the sacrum and the ilium. One of the most vexing kind of arthritis to diagnose in children is the child with systemic arthritis. These children get hectic fevers, which is typically quotidian in pattern, and along with that, they have several systemic features. Importantly, many of these children can present only with systemic features, and the arthritis can come later on. And this is the most challenging child to diagnose, especially because up to 1 in 5, 20% of them can present you very sick with remarkable lowering of the counts with a complication called hemophagocytosis or macrophage activation syndrome. So these patients are clinically very sick and will rarely come to the orthopedic team. And you have to be aware about this complication called macrophage activation. What about the subcategory of psoriatic arthritis? Infrequently seen because psoriasis in itself is less common in our country as compared to the white Western population. These patients classically present with a swelling of the whole digit or the toe, and this is then called dactylitis. Sometimes you can have extensive guttate psoriasis. This inflammation of the scalp and psoriasis looks very much like seborrheic dermatitis, with the key difference being that in psoriasis you can see the rash spilling out of the hairline, and this is very, very classical. So I hope I've been able to convince you that juvenile arthritis is not a single disease. There are many clinical constellations which are only grouped under the umbrella term of juvenile idiopathic arthritis. However, is every deformed and contracted joint juvenile arthritis? It is not. Because in children, they are developing, they can have inborn errors of metabolism, they can have storage disorders, and many children can present with mimics of juvenile arthritis. And let's see a few. So, this is a young girl who's 4 years of age. You can see she's got frank contractures of the digits, but the contractures are limited to the fingers, and you can see the wrist joint and the metacarpophalangeal joints are all normal. And this patient turned out to have a storage disorder called mucolipidosis. Excuse me. Here's another child who's come with remarkable deformities of the joint. But when you do the x-ray of this patient, what is classic here? This patient is 10 years of age and has hardly any carpal bones. And this is a genetic mimic, and it is carpal tarsal osteolysis. What about this child? She presents to us with what looks like a dactylitis, but this patient also has a swollen knee and a strong positive Montu test, and this patient has got a frank osteomyelitis of the phalanx here of the fifth digit, and this patient has got multifocal osteoarticular TB. So in these children, we would always want to run an HIV test as well. So this child is showing you that even with more than one joint, I don't have juvenile arthritis. What about this child? She presents to you with lots of aches and pains. When you do an x-ray, this patient has got iliac horns, and this patient has got abnormal nails, and this patient has got the nail patella syndrome. Why do you want to know about it? Because these children need to be monitored for renal function, and a small proportion can develop end-stage renal disease. How about this patient? Here's another one with multiple contracted PIPs, and can you see the anterior lipping of the vertebrae? And this patient has the classic format of SED TARDA, that is a skeletal dysplasia spondyloepiphyseal dysplasia, DADA. Excuse me. Sorry about that. So, pediatricians and orthopedic surgeons must be able to recognize the clinical patterns of these patients and then take appropriate help to give the child the best chance to do well. We are not discussing treatment in detail here, but remember that in order for the child to have a very good outcome, these patients should be recognized and treated quickly. Excuse me, 1 minute. Sorry about that. So that we need to understand that to treat juvenile arthritis, we have to know something called the window of opportunity, which is early on where we want to treat the patient so that they don't develop any joint damage. So that the cornerstones of therapy for every patient must be early specialist opinion and then early appropriate therapy. That's what's going to give you the best outcome. Remember the presence of disease activity and disease damage. If the child is left long enough without appropriate treatment, you're going to get complete loss of articular cartilage, and there's not a whole lot that you're going to be able to do to rehabilitate this patient. Additionally, clinical examination skills are so important. So we have two joints here. We have the ankle joint here and we have the knee joint here. Both are clearly swollen. But this patient does not have any associated marked erythema of the joint, whereas this patient does. This patient grew staph from the bone, and this was an osteomyelitis of the tibia with overlying skin erythema. And this patient, in fact, had associated uveitis. So, Dohler, Kaller, Ruber, what we learned in our undergraduate classes for arthritis holds true for the septic joint, not for the inflamed joint. So, clinical examination is extremely important. And when you look here and see this, emphasizes to you that looking at the child from the back will give you more clue about the ankle joint swelling. So in this particular patient, you will appreciate that the lateral gutters are empty on the left side, and here there's a significant swelling suggesting to you that the peroneal tendons are swollen with some tenosynovitis on the right side, and that is not seen on the left side. Again, I'm sure you'll appreciate that the ankle joints of this little infant are difficult to identify as to whether it's the left, the right, or indeed both. So we can have some clinical challenges, especially when we are evaluating the ankle joint. And today in our clinic, we use what is called POCUS, point of care ultrasound. And this is just like a stethoscope in the hands of a trained physician, and it's absolutely wonderful. We use it for all our children who present to us with swollen joints, and not only can we define is the joint swollen or not, but we can actually understand the exact anatomy. So here we have the ultrasound of two ankle joints. So this is the tibia. This is the open physeal plate of the tibia. This then is the talus, and this is the head and neck of the talus. And this area then is the tibiotalar or the main ankle joint. And you can see a clear synovium and fluid up here, and here you can see that the intra-articular fat pad is coming right down to the level of the cartilage. And so this patient has a tibiotalar joint effusion, and this one is normal. So point of care ultrasound is the new stethoscope and extremely important to use and extremely user friendly. And here you have a large swelling within of the tibiotalar joint. Here is the knee joint, and here is the large effusion and some synovitis which is seen in this knee joint. And here you can see a very large effusion with several fronds of proliferative synovium as well. And so I hope that I've been able to make you understand today that looking at children with arthritis is not child's play. Every child who presents to us requires a very careful evaluation. a detailed history, a careful exam, and only then with a few investigations can we understand what is the problem that this child is facing today. So thank you so much, and I'd like to end here and hand the mic back to Dr. Dharen. Thank you. And sorry about my cough, I apologize.
No, no, that's okay. We can understand because now, because of the viral infection, many of us have this problem.
So sorry.
Now, yeah, madam, you really explained that the history and the clinical examination is very important. Yes, that's very true for almost all branch of medicine. With the advancement in the investigations, something like ultrasonography, is there any change in the role of these investigations over the history and the clinical examination?
Absolutely. There's a lot of change. So, when children have swollen joints, only about 30 or 40% are going to complain of pain. So, you have to have a very careful clinical examination to understand is this joint swollen or not. Now, what happens in children is that many of them have a background of hypermobility. So, when you want to look at a deep seated joint, for example, the shoulder joint, you may find that the glenohumeral joint is clinically absolutely free. You may find that the child is able to do a full flexion abduction and take his hand right back to the opposite shoulder. But when you probe an ultrasound probe on the joint, you can find a significant bicipital tenosynovitis with totally normal examination in a deep joint such as the shoulder. Similarly, we find effusion and synovitis in the hip joint. And there, of course, many children will have a reduction of the internal rotation, but there are some who are hypermobile and the movement is totally normal. So, the most important thing it tells you is this joint involved or not? Second thing is it tells you what is the vascularity of this joint and how much of a synovium or fluid is there. And thirdly, in an area like the ankle, it gives you a lot of detail. It tells you is it the tibiotalar joint? Is it the subtalar joint? Is it the midfoot joint? Is there an associated tenosynovitis? Is there an associated enthesitis? And when you put all this information together, you are more confident how you want to treat the patient.
Okay. You have not covered the treatment. That's absolutely right. But I we should like to know, like there is a lot of advancement in the adult rheumatology with the new molecules coming up. Are these molecules being used in children also?
So that's an absolutely excellent question. Now, 10 years ago, we would have said that if the child has less than four swollen joints, inject it with steroid. If the child has more than four swollen joints, start methotrexate. If the child has significant sacroiliac involvement, give an anti-TNF. If a child has systemic arthritis, give steroid. So today, the whole paradigm has changed, and it's not how you treat a category, it is how you treat the particular child. What is the severity of the involvement? Which of the joints are involved? What is the functional limitation? And what are the extra articular involvement? And with all these components, we are able to design a treatment for the child so that if I have, for example, a child who has only a single swollen joint but has complicated uveitis, I will start that child on anti-TNF treatment upfront. I have complicated uveitis, which is vision threatening, and I have a patient who's very young, and I have a child who has mild joint disease, I might start on anti-TNF. Contrast that to the same subcategory. I have a mildly swollen joint. I have no uveitis. I may start the child with non-steroidal anti-inflammatory. If my patient has got a high titer rheumatoid factor and anti-CCP positivity and has got a high disease burden and has got poor prognostic joint involved, I might start the child on anti-TNF straight away. So how we treat depends upon the age of the child, the articular burden, the prognostic features, the extra articular features, and regrettably in our country, also the economic situation of the family. What can they afford? That becomes a very big thing. So in medical school and when we train abroad, we are not taught about how to manage the finances of the patient. That's never discussed. But in India, that's, front and center. So that even though we have very smart bullets, we have to really see, is that drug appropriate for the patient in front of you, for the socioeconomic context that they come from?
Okay, like say you describe it really well, but you did not mention anything about the investigation. So is it really very right in the decision making? You don't rely more on investigations.
Absolutely. So we rely upon investigations when we are concerned about mimics and when we are concerned about any drug toxicity. Otherwise, no investigation is going to lead you to the diagnosis of the patient. So, when we are looking at diagnosing a patient with investigations, we want to understand what is the pre-test probability of that investigation being positive. Now, in a child with juvenile arthritis, the rheumatoid factor is present only in 5%. So the pre-test probability is already so low, so we cannot take that test to diagnose this patient, right? So the rheumatoid factor can be present in tuberculosis, in infective endocarditis, in HIV, in childhood lupus, in overlap syndromes, in Sjogren's syndrome. So it doesn't give you the diagnosis for the condition. The anti-CCP is present in less than 5%. So it's a very sensitive, very specific test, but has a very poor sensitivity. When I look at the anti-nuclear antibody, the anti-nuclear antibody is only going to prognosticate the risk of the eye involvement. 20% of us walking around on the planet have a positive ANA. It doesn't help us in the diagnosis. When you look at a child with juvenile spondylitis, we know that 8% of India's population carries the HLA-B27 gene. Conversely, more than 85% of children who have juvenile spondylitis carry the gene. But because it's background positive in 8 to 10% of the population, it's normal. We cannot be reliant upon that test for the diagnosis. So, in short, no diagnosis, and I repeat, no diagnosis can rule in or rule out juvenile idiopathic arthritis. Juvenile idiopathic arthritis remains a clinical
Really
diagnosis.
perfect. Now, this session is being for the pediatric orthopedic trainees and the orthopedic surgeons. I would like to ask you, like, when do you take the help of pediatric orthopedic surgeons in the management?
Lovely. We take the help of pediatric orthopedic surgeons in the management on several occasions. So, early on, if we have any doubt about the diagnosis and we want tissue, we ask the pediatric orthopedic surgeon for help. If a child presents to us late and we have a joint contracture, for example, of the knee joint, if the child has a joint contracture of less than 10 degrees, I'm happy to sedate the patient, inject the patient, and put the patient to physiotherapy. I know the child does not require any stretch and cast. But anything in excess of about 20 degrees clinically, I know that patient will require a stretch and a cast. Now, for the orthopedic surgeon, when we are stretching and casting an inflamed joint, why do we want the help? We want the help because we don't want there to be a posterior subluxation of the tibia, for example, when we apply the plaster cast. We don't want, for example, the child to develop a foot drop if in case the plaster cast is not applied properly and you are going to injure the nerve around the head of the fibula, the peroneal nerve. We don't want that. So we want a skilled hand to help us with the stretch and cast of the patient. So that's the second situation where we take help of the orthopedic surgeon. The third situation where we take help from the orthopedic team is when we have a child who has got long standing disease and presents to us, for example, with an asymmetric valgus deformity of the knee joint, and we are seeing that the asymmetry is increasing over a period of time. We want the help of the orthopedic surgeon. When the physis is already open, we want to do a medial femoral stapling, right? When we have a child who presents to us late and the child presents to us with a significant hip contracture, and we know that there is ongoing disease in the hip, that the child has a very good chance of healing and getting better over a period of time, but the hips are contracted. So, what do? We take the help of the orthopedic surgeon to do a soft tissue release around the hip joint to buy time while we give medical therapy to the patient. Sometimes we may have patients who have very painful damaged joints, especially of the midfeet, and occasionally we may want an arthrodesis procedure done with the help of the orthopedic surgeon. We've had occasions where we have diagnosed the child to have arthritis because of an intra-articular osteoid osteoma, and that's where we want the help for either radiofrequency ablation or removal of that tumor which may be present. So we take the help of the orthopedic surgeon both for diagnosis and for management, for deformity prevention and correction, and we work as a team in many, many children.
Okay, then we have a question from Professor Hitesh. How to approach complicated juvenile idiopathic arthritis with infection?
So we have to then ask ourselves what infection and what is the nature of the infection. So if it's an acute infection, for example, my patient has got enteric fever, I'm going to stop all immunomodulator drugs. When we have a early diagnosis of childhood arthritis and we are not very sure what's going on, we can be complicating it with tuberculosis, and we have to look at TB very, very carefully in our patients. So what we need to know as orthopedic surgeons is that all monoarticular disease is not TB, and all polyarticular disease is not always inflammatory. So we can have children who have what is called Ponsets disease. In the context of fever as a reaction, these patients can present to us with acute or subacute polyarticular disease, but the underlying etiology is actually TB. And we can have children who can present to us with osteomyelitis. We've had a child who's had osteomyelitis of the fibular head and has presented to us with a knee joint effusion, and there is TB. And we've had children who've had osteomyelitis of the distal end of the femur with a reactionary effusion in the knee joint, and that is TB. So we have to look at the context of the patient. The rule of thumb is that if I have an acute infection and I'm running a fever and I'm on immunomodulatory therapy or a biologic modification, then those drugs should be acutely discontinued for the short duration of the infection and restarted later.
Okay, again, you have not touched upon the treatment, but how to treat sacroiliitis, hip synovitis, or enthesiopathy?
Okay, so when we have these three conditions of hip, sacroiliac disease, and enthesial inflammation, this category is what is called juvenile spondylitis. And again, we tailor the treatment depending upon what are the components of disease that this patient has got. So we need to remember that if you have a child with isolated hip disease, then juvenile arthritis is actually the last diagnosis. What we have to do is to exclude infection, exclude tuberculosis, exclude perthes, exclude slipped capital femoral epiphysis, and do a very careful evaluation of all the other joints before we label a isolated hip synovitis as being juvenile idiopathic arthritis. Now, when we look at hip synovitis in the context of GIA, it is seen in many subcategories in polyarticular, in systemic, and in enthesitis related arthritis. So, how you treat hip synovitis depends upon what is the category of the disease and what are the extra articular features that this patient has got. As a rule of thumb, I have a bias against injecting an inflamed hip joint. We would rather give systemic therapy, and if we have to use an intra-articular steroid, we'd be very careful that the child should not bear weight for at least 48 hours. And sometimes we will even use traction to distract the head from the acetabulum when we are doing an intra-articular steroid injection for the hip. So in our unit, we tend to avoid intra-articular hip injections with steroid, and we prefer using systemic therapy. This is one subcategory where it is involved. It can give a very adverse prognosis to the patient. So we are liberal with the use of biologic response modifiers in the context of hip disease. When we come to sacroiliac involvement, we know that conventional disease modifying agents such as methotrexate, sulfasalazine, leflunomide, cyclosporin, they do not work on the SI joint. There's some data that sulfasalazine may be effective. So some centers do try to use it. Otherwise, for children with sacroiliac disease, we are liberal to use two biologic response modifiers. One is anti-TNF agents such as etanercept, adalimumab, golimumab, or infliximab, or we can also today use interleukin 17 blockade, that is secukinumab, which is also available in India. Similarly, for enthesial inflammation, we'll either give a burst of non-steroidals. If there's an associated bursa with the enthesis, we may want to inject the bursa, or if the child is not responding, we would want to go ahead and use a anti-TNF agent, or we can also use anti-IL-17 or 12-23 blockade. So today, what has happened is the immune aberration pathways that are driving the joint inflammation have been very well understood, so that depending upon the category of disease and the severity of involvement, we can use biologic response modifiers. But an alert is that when we are playing God and changing the cytokine milieu of the human body, you have to take all the due precautions. You cannot willy nilly give biologics or small molecules to children. You have to do a very careful screen for tuberculosis, for HIV, for hepatitis, and only then give medication to these patients. In our own center, we've reviewed the use of anti-TNF. We have about 600 children that we treat with anti-TNF. Our background risk of latent tuberculosis is 14%. What is the country's background risk of latent TB in India? It's astonishing. It's 40%. So 4 out of 10 children have latent TB. We have 14% in our population because I'm working in an institution where we have a lot of privileged strata of society that comes, right? It's an expensive center. So we have children who come from a very privileged background and their latent TB positivity is 14%. Also, when you keep a child on long-term anti-TNF, remember that they are roaming around in this country. So they can get a secondary exposure to tuberculosis. And our secondary conversion on anti-TNF is frightening. It's 16%. Okay, so that when our patients are on prolonged anti-TNF, we have to screen the child every 1 to 2 years to make sure that he's now not developed latent TB. In our patients, we have a 1% risk of TB. We have 5 children who develop tuberculosis in spite of full screening. So nothing is fail proof. And therefore, when we use biologics, we have to be cautious. It is the right biologic for the right disease. It is a very careful screen and it is a repeated rescreen as well. So using these drugs is not child's play. No, we have to be very cautious.
Yeah. Madam, I have a question. What is the natural history of all different types? All you describe very nicely that, but what is your experience, long run experience? What they grow and what are the problems when they grow from the first decade to second decade to third decade?
That's a very nice question. So basically, whatever data we have with us available, a lot of the adverse outcomes were coming at a time when biologics were not available. So if you look at the outcome data of patients in the pre-biologic era, about 40 to 50% of these children would have significant amount of damage. So the damage can be measured by a score which is called JADI, which is Juvenile Arthritis Damage Index, where you can actually score the damage that the child is developing. And that damage can be localized damage or it can be systemic damage. It can be a reduction of the height, a very poor growth velocity, osteoporosis because of a lot of use of steroid, fractures, deformity, and a very poor quality of life. Okay. So this is all before the advent of the biologics. The first biologic was licensed by the US FDA in 1999, and that was for a drug called etanercept. So that in the last 2 decades, the children who have been seen early in the appropriate window of opportunity, which is within 3 months of disease onset, and they are given appropriate treatment and go into remission as defined by very careful criteria, those children have a fantastic outcome and they have no damage and they have a excellent quality of life. They have no joint replacement and no extra articular damage, right? So there are only two things that guide how is my patient going to do. One is how quickly did the child reach the appropriate team, the pediatric rheumatology team, and the second is how quickly did my patient go into remission, which is defined by standardized criteria. So that today, when we see the child, we do what is called a joint count. We do a core set as evaluation for every patient. So we ask the parent, what is your judgment from 0 to 10? How much disease does your child have today? The doctor gives a judgment between 0 to 10. What is the number I think the child has today? Then we count and see how many joints are swollen and tender of a 54 joint count or a 24 joint count or whatever outcome we are doing. Then we look and see how many joints are there with a reduced range of movement. And then we see what is called the childhood health assessment questionnaire as to what is the function of the child. And we look at all these parameters to judge how the child is doing, right? And we are targeting the child to remission. And this concept of treating then is called treat to target. So if you see a child quickly within the window of opportunity, you treat the child to target and you reach the target of remission or low disease activity within 6 months, these children have a excellent long-term outcome because we have so many molecules that we can switch to from one to the other if the child is not doing very well. Where is the problem? The problem is with late diagnoses when the child has already presented to us with damaged joints and then you're trying to rehabilitate the patient. All right. So in India, you will see that because the awareness of pediatric rheumatic diseases is so limited across the country, the referral pattern is when the family is frustrated, has been going from pillar to post for 5 years, they come to pediatric rheumatology. And up until now, they've been taking non-steroidal anti-inflammatory and Panadol injection, thinking the patient has rheumatic fever. They come to you after 5 years with 10 damaged joints. How can we talk of outcome here, right? So the outcome is in the context of when did the correct team see the child and how quickly did the child go into remission.
Great. One more last question, madam. Do you treat chronic non-infective osteitis?
Yes,
Yeah,
we
how
do.
to treat it? It's just not in GIA, but it's a very
Sure.
important question because
Sure, sure. So chronic non, so the CNO, that is a chronic non-bacterial osteitis,
yeah,
an inflammatory disorder
yeah,
which is seen in bones. It can either be as a standalone condition or
yeah,
it can occur in the context of several conditions. One of them is the juvenile spondylitis,
yeah,
and there are other syndromes such as the Sappho syndrome.
yeah,
The most important thing is a correct recognition of the non-bacterial osteitis and excluding primary immunodeficiency, specifically looking at the immunoglobulin profile of the patient and making sure the child does not have chronic granulomatous disease by running the NBT-DHR. If in case the child has a single first metaphyseal lesion, those children will sometimes be subjected to a biopsy to clarify the diagnosis of the patient because you're not very certain what is the reason for that bone marrow edema. There are a lot of well described features which are there today on a whole body MRI. So today in our hospital, if we have a patient where we suspect the child to have classic NBO, but the child has only a single lesion, we get a whole body MR done to look for silent lesions elsewhere. Now, once you are able to confirm the diagnosis of NBO, there are several pathways that you can choose. For the very mild inflammation, you can go ahead and choose a non-steroidal anti-inflammatory and see the response of that patient. If in case the child does not respond to non-steroidal, you could then use a bisphosphonate. In our hospital, we tend to use the drug called pomegranate, where we give 1 milligram per kg per dose, and we give at least 3 infusions monthly before we decide how the child is doing. We then may give a gap of 3 further months, and if needed, give 3 more infusions. Now, if after 6 infusions this patient is not showing you a major improvement, both clinically, serologically looking at the acute phase response, we would then switch the medication. The other choices we have are to use methotrexate or in some situations to use anti-TNF therapy. If in case we have a patient who has spinal NBO, those patients are prone to developing vertebral collapse. So to prevent the vertebral collapse in those patients, the better drug is a bisphosphonate as compared to an anti-TNF. What we also need to remember is that if the patient has silent NBO lesions in the peripheral skeleton, has no complaints, we don't treat those silent lesions. The only silent lesion that is treated is the spinal lesion because of the risk of vertebral collapse.
Yeah. Thank you. That
Yeah,
would be the
Madam, the one basic question. I have observed that most of the rheumatologists and pediatric rheumatologists, they prefer naproxen over the ibuprofen. So is there any reason for the safety or the efficacy, or it's just like by tradition you are using that and that's you are continuing that?
So you're absolutely right. Our go-to drug is naproxen. That's because it's an easy twice daily dosing, available both in syrup and tablet formulation. Otherwise, you are aware that the non-steroidals belong to different acidic groups, and it's like a menu choice. If I go to a Chinese restaurant and you like fried rice and I like noodles, we are both right actually. So it's a menu choice, and you can give any drug to the patient. Keep in mind that the potency of these non-steroidal depends upon the lipid solubility. And the more the potency of the medication, the higher the side effect. So the most lipid soluble amongst the non-steroidals is indomethacin. It's extremely effective, but has the highest side effect profile as well, right? And then you have the other drugs such as naproxen or ibuprofen, which are modestly lipid soluble, have a modest effect, and are very safe. We are not very particular about using COX-2 inhibitors in children, but if we are using a long-term NSAID for say 6 or 12 weeks in the context of a child with sacroiliitis or enthesial inflammation or NBO, then we may sometimes use a COX-2 inhibitor, and our go-to drug is etericoxib. I think it's important to familiarize yourself with a couple of agents and then use them. That's what is my practice.
Okay, yeah. So that's the practical thing. Rather than trying new molecules in every patient, be sure and like comfortable with one or two molecule. That's the
Absolutely.
yeah.
All these newfangled drugs, they don't have a huge amount of benefit. They're just marketing strategies. It's like the mutual fund industry. They're not allowed to launch more than one mutual fund in one area. So they keep launching a new one every 6 weeks because they can't repeat a mid cap fund. Yeah. So they'll say, I don't know, technology mid cap or agri mid cap, and they keep reinventing the wheel. It's worthless exercise, not required.
Right. Thank you, madam. At the end, I sincerely thank you for like insightful and practical talk. This was not only a theory, but it was combined with a lot of insights from the vast experience. And you explained the concept with great clarity. And more importantly, you made it very easy to apply in day to day practice. So I'm confident that, fine, we cannot replace the rheumatology branch, but at least we can refer the patient at right time. And as you rightly said, that early diagnosis and early treatment is very important in such condition. So I'm sure that this session will make our colleagues aware that we need to refer to the experts when it's needed. And I shall also like to thank our participants who have joined this session in the Zoom meeting. And I'm sure that a lot of them are very smart and they watch this program, the live streaming, or at their convenience. So thank you all the people, and my heartfelt thanks to entire team of OrthoTV, because your invaluable help with promotion as well as the seamless live streaming will help us to reach this message to the wide audience. So with that, thank you and good night.
Thank you so much. Thank you. Bye bye.
Yeah.
Thank you.
Bye
Bye.
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 Bye.